大家好，我係 Sosan。如果你聽到荷爾蒙治療就感覺驚，甚至乎覺得有風險嘅話，或者你曾經又話，聽人講忍下啦，更年期就係咁嘅話，咁呢一集你一定要聽啦。喺 Simply Sosan Podcast 呢一日啊，我就激請咗我哋嘅荷爾蒙專科醫生 Dr. Jennifer Zelovitzky。咁佢係用最新嘅醫學嘅研究啦，幫助我哋去拆解 HRT，就係我哋最驚嘅呢個荷爾蒙治療，究竟對我哋安唔安全咧？咁同埋講，我哋會傾下常見嘅迷思啦，包括佢哋嘅安全性啦、乳癌嘅風險，同埋邊啲女性適合啦。同埋呢一集咧係以全英文，係一個 bonus 嘅 episode 嚟嘅。咁內容係非常之清楚、簡單同容易明白。所以如果你話更年期係一定要忍啦，希望睇完呢一集之後咧，你就發現你係唔需要忍，你係有多一個選擇。而喺呢個訪問咗之後咧，我亦都會同大家分享下我聽完咗之後我自己個人嘅見解。我哋一陣再見，而家開始。
Welcome to Simply Sosan Podcast. I'm your host, Sosan. I am so honored to have guests today because I know you are all always wondering this three-letter word that scared women for last 20 years. And what are that three letters that scares women the last 20 years? HRT, hormone replacement therapy, right? We hear that, we say, oh, breast cancer, right? So that's why I'm so honored to invite my guest today, because we will debunk all that and talk about it so that you can make an informed choice. What is it? Who is it for? And how to talk to your family doctors about it. And before we start, let me introduce her. Wow, what an accolade of achievement here. Let me introduce. So here we are. We have Dr. Jennifer Zelovitzky, is the Clinical Director of Women's Health and Vitality at MedCan and leads in perimenopause and menopause programs. She's a North American Menopause Society certified practitioner, so she's a menopause specialist. I'm so happy that we have something local because so many menopause specialists tend to be in U.S. Like, obviously, one of them is a well-known Dr. Mary Claire Haber that people follow, but I'm just so happy that we have someone locally that are a menopause specialist, so I'm so excited about that. And she is also an interesting backstory that you were working in finance at Bay Street in Toronto before attending medical school. I have two daughters and 3 fur baby, and she loves to talk about menopause, misconception and education gap that's just around women's health. And that's why I said you're in for a treat. You definitely don't want to miss this episode. And I want to say thank you for joining me, Dr. Zelovitzky. So let's start off the number one thing that people often ask. Let's talk about the myth. People are so confused, even fearful, including myself, HRT, or even nowadays they call it MHT, which you can talk a little bit about that, about the open. What are these common myths and misunderstandings that women still have that get them so scared of this particular treatment?
Yes, well, there are so many. Obviously, first of all, thank you for having me, Sosan. It's wonderful. It's wonderful to be here. And I do love dispelling those myths, right? Because there are so many of them. And unfortunately, it's not just women, it's doctors that also perpetuate these myths. So the first one would be that hormone therapy causes breast cancer. The second would be that if you have any family history of breast cancer, for 10 generations, you cannot be on hormone therapy. And the third would be that you have to wait until you're fully menopausal. In other words, you've gone a full calendar year without a period before initiating hormone therapy. I would say those are still the big three.
Yeah, and you're right, because I only up to now recently when I started doing research, I realized I myself kept thinking that if anyone considers HRT, it's after menopause. Like, I never even think about perimenopause and the whole HRT, right? So let's talk about what is HRT, or even nowadays they call it MHT, which is menopause hormone treatment. So can you talk a little bit more so that people know how's that different from the traditional HRT, or nowadays people said bioidentical hormone? Is that better? How is that compared to the synthetic form, basically?
So HRT is synonymous with MHT, menopause hormone therapy. It's away from that hormone replacement therapy nomenclature because women feel like menopause is a diseased state where you have to replace your hormones. That is not true. You're not missing out. If you're somebody who doesn't have symptoms and you're thriving through perimenopause, you're not missing out on anything by not having hormone therapy. Rather, menopause hormone therapy means that you may, if you're having symptoms, benefit from supportive treatment, which may include hormone therapy or may include non-hormone therapy, and certainly will include some lifestyle recommendations and modifications, all of which can play a role in thriving through perimenopause. And then with respect to bioidentical, unfortunately, this was a marketing term that arose as a result of the Women's Health Initiative debacle. I'm speaking to you on a historic day because the FDA literally right before we recorded this announced that they are removing the black box warnings about breast cancer, probable dementia, and cardiovascular disease from most hormone therapy products. This is a better reflection of what the science has told us all along. However, after the Women's Health Initiative 20 years ago, which scared women off of hormone therapy, women were desperate for something to turn to make them feel better. And the only place they could get them was through natural health doctors or other providers who would give them compounded creams off-label. And they said these were bioidentical, and the implication was that they were targeted to your specific levels, which is not possible or required, and that you were getting a personalized, customized, safer option to hormone therapy, when in fact the opposite was the case. We know that the so-called compounded bioidenticals are not manufactured in a Health Canada regulated, safe, consistent, or sterile fashion. And what this means is you don't actually know how much estrogen, progesterone, or testosterone you're getting in that pellet. You don't know how much you're getting in one batch of compounded cream versus what you pick up a month later. There's no regulation. This is why they're always checking your blood levels. And this is why it's actually a red flag to be told that you constantly have to be checking your blood levels. I'll do a baseline level if there's, a question about where you're at in your menopause transition, or maybe whether you might benefit from estrogen, or if you're still clearly producing a lot of it on your own, or even just to rule out other potential causes for your symptoms. However, if someone says we need to constantly check your levels, that's a huge red flag. They just don't know how much they're giving you. And what I see in practice when women switch away from the compounded formulations to Health Canada regulated formulations, they often come to me with testosterone levels that are far in excess of normal female levels, estrogen levels or estrogen side effects, I should say, that are in excess of what they should be having, like excess bleeding or thickening of their uterine lining, and not enough progesterone to protect that uterine lining, because progesterone does not absorb properly as a cream. That's why there are no formulations of progesterone creams, really. There are some options if you can't tolerate oral progesterone, but that would not be the one I'd go for. So I'm sorry, that's a long answer, but it is a long 20-year history to unpack in terms of how we got here with the bioidentical terminology.
Oh, I got it. And I feel like there is still so many unknowns. Just to hear that the FDA is going to do a black label, that to me is such a big step forward for women around the world to end this unnecessary suffering. I guess you and I will be agreed that this is not saying that the MHT can help everybody, but obviously we often talk about in health, it's a toolbox, it's one of the tools in the toolbox, right? And when you said that, I think a lot of people think they're all the same, but now when you explain the difference, wow, just hearing that, because I think, especially in my world in the nutrition and health one, everything sounds natural, always seem to be perceived as safer and better. And I often say, not necessarily. And this is unfortunate. It's that marketing, a little bit of the marketing gimmicks that kind of go around that, because they see that. They just look at food. As long as they put natural sugar, suddenly the sugar sounds better. But it's still sugar, right?
Still sugar. And Dr. Jen Gunter, calls these God terms. They give you that implication of safety, safer option, more natural, I mean, I can reassure you, most of the formulations of hormone therapy that I prescribe are body identical. They're structural and chemical clones of what your ovaries produce or used to produce. So I always say to women, your body's interpreting these as natural, as coming from your own ovaries. And this dramatically reduces the doses we have to use and the side effects that women tend to experience when they start these formulations, which is fantastic.
Yes, it is. And just I think feeling reassured, I think we often say it's similar to supplement. The quality exactly is so, because nowadays you see so many supplements out there and the prices vary, right? But when you really look at the kind of the key ingredient, the dosage, it's a trademark ingredient. It makes all the difference right there.
That's right. If you see a custom formula or a proprietary formulation, that's a red flag too.
Yes.
Something so many people don't understand is that there is no Health Canada oversight of supplements. It is buyer beware. I'm not saying that targeted supplements like vitamin D, calcium if you need it, B vitamins if you need it, are not safe and a good idea if I always say go with brands that are tried and true, that have been on that shelf for decades and that they're obviously performing up to a standard. But the truth is they are not rigorously tested in any clinical trials. They don't have to. Why would you, if you were the supplement manufacturer, why would you spend money that you don't have to spend on constructing a clinical trial to prove the efficacy and safety of your product?
Yeah.
So for example, I can just pile all of the menopause supplements or hormone balancing supplements into one pile of there's no evidence for this because there simply is not. But I understand women turning to them and trying them because they're desperate and they are scared of hormone therapy. And hopefully today is the first day that we can start to see that shifting away.
Yeah.
Mm-hmm.
This again I think the whole marketing was done so well that a lot of people start to get very confused and they always think more is better, and that's not necessarily true because in the end I think people doesn't want to work on the lifestyle. So that I'm going to jump on the lifestyle part because we know that this is one tool in the toolbox, right? But lifestyle is a very important tool in the toolbox. Can you kind of talk about it so that people, for women who are considering knowing that, okay, maybe if I do the MST, I'm good. I don't need to worry about the food, the nutrition, the movement, because MST is resolving all the problems.
Yes, I see that all the time. The truth is that perimenopause symptoms are multifactorial. Yes, a lot of them are driven by fluctuations and changes in our hormones and the decline of estrogen over time, but we are changing our lifestyle as a result of the symptoms we're having. And this is the way that we actually start to see cognitive decline, irritability, weight gain. These are the things, mood changes, these are the things women are always asking me about, and they want the hormone therapy to fix it. And I say, well, I can give you all the hormone therapy in the world. It's not going to lift the weight for you to put your muscle mass back on. It's not going to get you to turn your computer off and get 7 or 8 hours of sleep. It is certainly not going to fix your interpersonal relationships, your overloaded basket at work that you're taking on too much to possibly cope with. It's not going to give you back work-life balance. It's not going to help you eat the more nutritious foods that you need. Mm-hmm. An interesting statistic I learned recently is that women in the menopause transition eat about 380 calories more per day than they did prior to the menopause transition. And so I'll have women say to me all the time, I'm not doing anything differently and I'm gaining weight. Well, that's why you're gaining weight, is maybe you're not doing anything differently. And also you are probably doing things differently, but not aware of it. For example, we were just talking about how hard it is to get to that workout when you're exhausted. You're not sleeping. The downstream effects of that on your lifestyle are profound. And interestingly, it doesn't really matter, according to the data, how you correct that sleep deficit. Whether it's if you're sweating all night, then it's probably going to be hormone therapy that you need. but you may have sleep apnea. You may be just forcing yourself to stay awake because you're worried about getting all the work done, or you're stealing back that time at the end of the day, right? Because you're so busy doing for others all day. But you have to get to the root of the sleep issue, because it doesn't matter how you fix it. You need to be getting good quality and duration of sleep, because the downstream effects of poor chronic sleep deprivation are profound. That is actually what leads to higher cardiovascular disease, dementia, weight gain, etc. So yes, I can facilitate hormone therapy if I think that's going to help your symptoms, but the lifestyle component is crucial. You cannot have one without the other. The MHT is to facilitate the lifestyle changes you need to do to improve your overall quality of life.
Yeah. No, I totally agree. I feel like it's very similar in a way. Think about the GLP-1, when people on the GLP-1 wagon. And I do have people ask me about GLP-1. I said, this is only one tool. It does not mean you have a GLP-1 and you lose weight and everything is fine. Because like you said, a lot of people, when they have poor lifestyle, even on a GLP-1, they might not see that result that they were looking for, basically.
Right.
But I think as human, we often looking for that magic bullet, that one magic pill that kind of resolve everything. And to tell them that you need to work on your sleep, you need to work on movement, you need to manage your stress, because like we all agree, the age that we're in, it's stressful. We have kids, all right? We're in the sandwich generation. We have aging parents that need our support. We still have a career, right? So all that together in this very confusing world that we live in, a very challenging world that we live in, it is stressful, right? As much as I would love to have the MHT to resolve everything, the reality it's not going to be. And I hope this will allow people to know that, yes, this is one of the tools in the toolbox, but the foundation is still your lifestyle. That's not going to change, basically.
That's correct. And you want to be receiving your hormone therapy alongside counseling, similar again to a GLP-1, right? I often meet people who are on a GLP-1 and they are getting thinner, but they are not getting healthier because they're not doing the work. I'll have someone say, it's great, I'm losing weight, but the side effects make it so the only thing I can really tolerate is cake or ice cream. So that's what I eat. And I'm like, well, this doesn't seem to be the intention of this medication, is to make you so nauseous, for example, that you can't tolerate healthy, nutritious food and you can't get yourself to lift a weight. Because one of the risk factors for osteoporosis is rapid weight loss in adulthood. So if you look at women, especially women at midlife who are using GLP-1s and they're undergoing rapid weight loss, because this is what these medications can induce, are we going to see an explosion of osteoporosis in 10, 15, 20 years, where we have a lot of very thin women in nursing homes because they've broken a hip and lost their mobility? So GLP-1s are also meant to be part of that toolkit. As you said, you are supposed to receive them through a comprehensive program that gives you the nutritional advice, the muscle maintenance advice, and the mental health support that you need to cope with the changes in your body that are going to come about as a result. It's another hormone impacting medication, so it is analogous in a lot of ways.
And which leads to the next question, because I think now that we can finally telling people is not to worry about the whole breast cancer, because that was 20 years ago, is no longer true. I mean, there are benefits and there are risks. Let's talk about the benefit. I think one of them is the osteoporosis. Can you elaborate a little bit more about the lesser known benefits that people can expect?
Yes, that's a great question. So osteoporosis is thinning of the bones that can happen, and it doesn't wait for that final period. And it certainly doesn't wait till age 65, which is unfortunately when the Ministry of Health authorizes women to get baseline screening unless they're high risk. It starts in the menopause transition. I scan women starting at age 50 at MedCan, and I'm more surprised when they have normal bone density, frankly, than when they haven't already undergone some degree of bone density loss, not osteoporosis, but maybe low bone mass, because these changes start several years prior to that final menstrual period as estrogen levels start to fluctuate but overall decline. And this is a silent symptom. So rarely will women come to me and say, I'm interested in starting some hormone therapy because of bone loss. It does happen a little more now because of heightened education and awareness, but it's a silent symptom. You're not aware of it happening, right? And this is why many women are getting that bone density at 65 and shocked because they have osteoporosis. And then what do? You're turning to medication to help try to preserve your bones. But what hormone therapy can do is help to prevent bone loss. And I see this in my practice all the time. I'll see women who stabilize or even improve their bone mass slightly through hormone therapy and a combination of lifestyle factors like vitamin D supplementation, a good exercise routine, etc. I do think that is one of the unknown benefits. A lot of the other little known benefits are things that we don't necessarily prescribe it for, but we know that for women who are on hormone therapy, they can experience a reduction in diabetes, so fasting glucose, because that was shown in the Women's Health Initiative, that women who were on hormone therapy had a reduced risk of diabetes, reduced risk of colon cancer, reduced risk of cardiovascular disease, but there are a lot of caveats there. You know, you have to be at the right age range. It was a specific type of hormone therapy that was used. However, it is not known, and I want to make this very clear, it's not known whether asymptomatic women are going to have those benefits. It's possible. It's possible because many of the women in the Women's Health Initiative were asymptomatic. That's another long story, but they didn't want women to know for sure if they were on a placebo or not. So they actually sought out mainly women who were asymptomatic, and they still saw those benefits. However, the official word is that we know it's the vasomotor symptoms and the lack of sleep that drive cardiovascular risk, cognitive risk, weight gain, etc. So yes, you can experience other health benefits from being on hormone therapy, but in the absence of hot flashes, we don't necessarily know for sure if you will have that same benefit. Time will tell. I hope that there will be more research. I hope that we will have a lot more data forthcoming. And the other thing I want to just clarify with respect to breast cancer risk, yes, they're removing the labels with respect to new onset breast cancer, but there has always been a question that's unanswered and the reviews are mixed. Whether you already have an underlying cancer, whether hormone therapy can prompt it to grow. So this is why it's crucial to get your mammograms. Just as a sidebar, if you are 40 and above in Ontario now, no doctor's referral is required. You can self-refer for your screening mammograms, and I could not recommend it more highly that every woman starting at age 40, if you're of average risk, go and get that mammogram. You want to know if there's potentially an underlying nodule that has to be managed before starting hormone therapy, and you just want to know because early detection is the difference between cure and not cure. So that's a side note, but I just wanted to make that very clear. You have to know you don't have an underlying.
Yeah,
Yes,
and that's so important information because I think in Ontario, we often are waiting for the doctor to say, okay, it's time to do a certain test, you do it. And I'm always advocating we need to be proactive, right? Because the doctors, yes, I mean, if you're high risk, obviously they do pay attention, but sometimes 40, for a lot of women, they don't think they're high risk for anything yet, right?
Of course not. Yeah. They're invincible.
To know that they don't need the doctor's referral, that would be, I think, such an important thing. I hope that women who are listening to this, who are in their early 40s, it's never too late. It's always good to have a baseline to look at because if any changes, you can see how your breasts look like when you were in the 40s versus, I don't know, in your 50s, for example.
Absolutely. I've had 4 or 5 mammograms now, and it feels empowering in a way. It feels very empowering to go and know that I am taking charge of something, that if something is there, the cure rate for early stage breast cancer is now almost 100%. That's a profound difference. And don't forget, back when the Women's Health Initiative took place, breast cancer was not easily cured, and it was not as easily detected. We didn't understand as much about it then as we do now. And so I do understand how any question mark about potential breast cancer risk was enough for everybody to pull the plug and put these warnings on, but they weren't looking at the data carefully. And that's where I take issue with it. Estrogen was never shown on its own to increase breast cancer risk. So that led to generations of women not only not having access to hormone therapy, but not even thinking about what the menopause
the fear was so big.
Was.
Yeah.
It shut it down, and it shut it down for researchers, and it shut it down for medical educators. I learned nothing. I didn't know the word perimenopause as a medical student, and it's embarrassing. Every time I tell this, I can't believe I'm saying it, but it is the truth. And to this day, I had a patient the other day who said she went to her doctor and said, I think I'm in perimenopause, and her doctor said, that's not a thing. So we have come far, but thank goodness you're having conversations like you are on your podcast, because this is so badly needed. We need to reach women directly because they need to go to the doctor and they need to advocate.
Yeah.
And soon they can take with them, in fact, it's already online, the FDA.gov fact sheet about what they're removing and why, and you can take that to your doctor and say, look what just happened.
Yes.
And hormone therapy.
Yes, and with you sharing that, I feel like, wow, perfect timing to talk.
Breaking news. Did you know you were going to be breaking news? I asked you if we could start a little bit later our recording today, because I found out this morning that they were making the announcement right at the moment we were starting, and you very graciously said, yes, watch that announcement. So I'm rewarding you with that, being first to know.
I'm so happy to hear that. It makes me feel so reassured, and people feeling so reassured to know. When you talk about doctor, I feel like a lot of women, I feel like somehow maybe it's the way the society is, we become so timid to ask for things. So how, now that they hear this podcast, they say, okay, you know what, I'm having symptoms and everything. I'm thinking about it. How should I approach my family physician to talk about this? Is there any tips that you can help them to kind of to navigate asking the right question? And hopefully, well, I'm just hoping that in a few years from now that more and more doctors are educated in this area and feel reassured that when they are making those recommendations that they are safe and there's no more concern, there's no more myths anymore, and that we can move on, basically.
Yes. So I would say don't ask any questions because your family doctor probably statistically won't be able to answer them. And if they're answering them, their answers are probably outdated. You need to actually take charge. What I have seen work for some women is to print out the guidelines from the Menopause Society, formerly known as the North American Menopause Society, but their statement about hormone therapy is public access. If you go to the Menopause Society website, they have a patient information section where you can access pretty much the guidelines or the statement on use of hormone therapy. Take that to your doctor. Highlight the section that talks about the ideal candidate for hormone therapy and contraindications for hormone therapy, and say, I've reviewed these thoroughly. I don't fit any of the criteria for contraindication, and I do fit the criteria for a good candidate for a trial of hormone therapy. And unless you see anything to the contrary, please tell me. If you know something that I don't know, tell me. So I would like to try a 3-month trial of name your hormone therapy, an estrogen patch and a progesterone capsule at bedtime. I'd like to try this for 3 months, and then I'd like to book a follow-up with you to discuss how I'm responding to it and how it's impacting my quality of life and my ability to continue with my work, family life, obligations, etc. And then you and I will make a decision about whether we adjust my dose, continue my dose, or discontinue it. Unfortunately, this is where we're at right now in terms of advocacy, but this can work. Now, if your doctor says, no, I'm not comfortable with this, ask them to refer you to a qualified menopause practitioner with the caveat that the OHIP-funded options are a very long wait right now. I think it's a 2-year wait list.
Wow.
Because there are so few. Little known fact, we don't have a billing code for menopause care in Ontario. Meaning, I cannot just go hang up a shingle in the public system and bill the government to help women with their menopause care. I just can't do it in any way that would allow me to keep my clinic running for more than a day. So there are some gynecology-based clinics like Mount Sinai Hospital that do offer menopause care because it's a specialist team of gynecologists and it's done within a hospital setting. And that's why their wait list is so long. And rightfully so. They need to see the high-risk patients. They need to see women who simply don't have the means to access care outside of the public system. And there are a few sporadic gynecologists around who will prescribe menopause therapy. But this is why so much of it is privatized. And because we can only really offer it privately, which is not because we want to, it's because we actually have no other choice. But the good news is there are a lot of options at a lot of price points now available within the Ontario healthcare system. There are some wonderful nurse practitioner-led clinics. There are some text-based clinics. There's a variety of options in terms of private pay, in terms of the cost and what you get for it. But all of them are evidence-based, and this is what is so wonderful. So you no longer have to turn to the hormone clinic on the corner that's giving you compounded bioidenticals. You can access Health Canada-approved formulations from a variety of sources.
Well, I just want to say for those who are listening, it is so sad to hear that in Ontario, the OHIP system doesn't even have a billing code for menopause when we have more women than men, and every woman bound to go through this phase in life. It's not like there's someone skipped this phase. Everyone goes through that, but yet, like we talk about diabetes. Not everyone's diagnosed with diabetes. Mm-hmm. Not everyone's diagnosed with cancer, but every woman will be going through this, and yet there's no billing code.
Yes, and this is why less than...
to explain how I feel at this moment hearing that.
This is why less than 15% of women still report having no relief or no support for managing their symptoms. It's a tragedy. It's a tragedy, it really is. And, there are people who advocate as much as possible. This is why I am always happy to educate and talk and coach women through talking to their doctors, because sometimes that does work. And if it doesn't, at least you've brought their attention to it. Maybe they will go and read. Maybe they will try to educate themselves. But we have a long way to go.
At the same time, we're hopeful. Things are moving in the right direction, basically.
Today is a monumental day, and it's an important step in the right direction for women's health. We have more work to do. We certainly need Health Canada to follow suit. And they usually do. They look to the FDA as their North Star in a lot of cases. So I'm very hopeful we'll see similar black box warning removal. We can just rip it up for now and say, we don't need to worry about this anymore. Yeah.
What's the first step is obviously approaching their health practitioner, but knowing that at the same time, there are, unfortunately, it is a private, but in the end, there is options. I think that's something that I will definitely link the guidelines in the show notes so that people are looking to get more information. They can easily find that. I will link some of the clinic because I went to the National Menopause and I saw some of the clinic. So at least people can go and explore that option. I remember some of my clients when they were needing some service, and I said, financially, why wait for treatment when there are options, basically?
Well, and the truth is women have been paying privately for menopause care ever since the Women's Health Initiative shut it down. They've had to turn to the corner store compounding provider who, frankly, I just see as doing a complete disservice for women, but women were desperate. So better to spend your hard-earned money on something that is approved, safe, and under the guidance of an evidence-based practitioner than through someone who is not practicing evidence-based care and may in fact cause you harm.
Yes, for sure. And I think today's episode will provide a lot of reassurance, but at the same time, knowing that you still have options, right? I think that's important. I think sometimes for women that are saying going through the menopause is challenging, suffering is not acceptable. I totally agree with that. Suffering is not acceptable. Now I'm in my 40s. Something just occurred to me. I said, wow, if I live to 80, I still have another 40 years, or 30 odd years to go.
Mm-hmm.
How could I just give up? Many women go into this and they were suffering. They just kind of give up and just accept the fate and that's aging. And when you talk about the osteoporosis, I feel that, nowadays a lot of the message was being strong is the new skinny. It's much better because being strong protects you in so many different ways. And even I myself start lifting weight where I used to do, I'm the cardio, everybody doing cardio, right?
Me too. I totally understand that. Me too.
So I would love for you to kind of the final question was, if you have a message to share with women over 40, what that message would be.
So I would say that menopause itself is one day in your life. It's the day that you've either had a surgical menopause or you've gone a full year without a period. And I think we can finally start to take away the importance, if you will, of that one day, because it used to be a finish line. And now I think it's just a seamless transition because the symptoms of menopause start up to 10 years before that final period and can continue after it for many women. And we no longer have to white knuckle it to that finish line. We can almost make it a non-event by managing our symptoms when they start, taking charge of them, and thriving through the menopause transition. We finally have the tools and the knowledge to do this.
Oh, thank you, thank you. As you were making your final message right there, I was like, hey, I still have one question that I want to ask, which because some of my audience are people who are way past menopause. I think the question that I would love to ask, and they would want to know, when is it too late for me to start MHT? Because I might be in my 65 already. What are your thoughts or what are your suggestions?
So it is best and safest to start if you're in perimenopause or if you're already past menopause, if you're less than 10 years from your final period. I meet women all the time who have that final period at 54, 55, even 56. And this means they have that 10-year window beyond that to most safely start hormone therapy. However, it's never an absolute no. I have met women who are the epitome of health from a cardiovascular standpoint, and they have had nonstop hot flashes since they went through menopause. And they are, in fact, good candidates, even if they're a year or two out from that 10-year window. You want to speak with a very knowledgeable physician about that. And vaginal estrogen is safe for every woman at every age, and you can start it at 99, 105, whatever you want to start. If you're having dryness, frequent urine infections, bothersome symptoms from a genitourinary standpoint, start vaginal estrogen yesterday.
Wow. No, this is so reassuring. I hope that this episode really give women a chance to realize that they do have tools and they can totally, it's not for everyone, but certainly it's not something that we need to rule out because we've been ruling that out for so long. And this has been a very helpful tools for everyone. Follow you, find you, or if they are downtown Metcan, how can they find you if they're looking?
You can call Medcan if you're interested in finding out about our program there. However, to follow me in social media, it's Dr. Jen Zello on YouTube and Instagram. And I do share a lot of information about hormone therapy, menopause, women's health in general. And so those are the best ways to find me.
Okay, I will definitely link all these links in the show notes so that you can go and find them. Thank you very much for your time. I know how busy you are. I really, really appreciate it.
It's been an absolute pleasure. I'm happy to share such a happy news day with your audience, and thank you so much. It's been a pleasure.
Hopefully we can invite you back and we can talk more.
There's a lot to discuss. We barely scratched the surface.
Yes.
喺呢個訪問之後咧，我好想幫大家整理一啲嘅好重要嘅重點。第一嚟講咧，關於呢個荷爾蒙治療，即係而家我哋稱呼佢叫做 MHT 嗰陣時，最大嘅問題咧，唔係我哋究竟用唔用啊，而係我哋有冇得到個正確、最正確啦、最新以呢個證據為基礎嘅資訊。第二嚟講咧，而家喺嘅 MHT 咧，比以前嘅選擇多好多啦。我哋係有唔同嘅劑量啦，唔同嘅形式啦，亦都可以決定到究竟邊啲人係適合嘅。呢個係好講究我哋個人化嘅評估，而唔係一個標準嘅答案。而另外咧，好重要咧就係話除咗呢個 MHT 嚟講咧，我哋個人嘅生活習慣啦，亦都扮演一個好重要角色，包括我哋嘅睡眠啦、我哋嘅壓力啦、我哋嘅飲食啦、我哋嘅運動，呢啲全部都係影響我哋喺呢個更年期期間咧係覺得舒服啦，或者係辛苦啦。我希望你聽完呢集之後啦，就唔好再有恐懼啦，反而咧係多份理解之後咧，知道自己有咩選擇，而唔需要強求叫自己捱落去啦。更年期就係咁樣噶。咁我希望咧聽完咗之後咧，你可以咧去同你個醫生去溝通，有一個溝通睇下究竟你適唔適合去用呢個治療，而幫助你喺呢個更年期係覺得開心而舒服，而唔係痛苦嘅。咁如果你覺得我呢一集訪問嘅嘉賓對你嘅了解多咗，亦都對你嘅幫助好大嘅話，不妨幫我 share 出去俾你更年期嘅朋友，我哋一齊為自己嘅未來嘅健康繼續努力，我哋可以掌控我哋嘅未來啦。我哋下次再見，拜拜。